morning. We are so delighted to meet you in the program of Tea Kadai Bench. Good morning, sir. So today we have received one case. So shall we discuss?
Yes, of course.
Okay, sir. So 31 years old male patient presented with 6 days of fever, dry cough and breathing difficulty, sir. So on clinical examination, he was found to have crepitations over a right infrascapular region.
Fine.
Then chest X-ray revealed patches. So patches over right lower lobe, sir.
Okay.
So
only in the right lower lobe.
yes, only in the right lower lobe. Then his routine investigation revealed CRP around 250.
Okay.
Then there is a leukocytosis, sir. WBC count around 21,000.
Okay.
Then his blood sugar level is 521.
A newly, it's a known diabetic or newly
No,
detected?
sir. Not a known diabetic,
So
sir.
he has been detected to have as a newly detected.
Yes, sir. Newly detected diabetic.
What is the age, patient age?
31
years.
31 years old.
31 years.
31
Okay,
years,
fine.
So, how will you approach this patient, sir? So, chest X-ray, patches, then fever, dry cough, crepitations.
Okay.
So
it looks like more of pneumonia.
So, what about pulmonary edema, sir? Can we think of pulmonary edema?
Pulmonary edema must be a different story. See, pulmonary edema, of course, they will have crepitation, but the most important is they will have crepitations on both the sides. That's very, very important. So this patient presented with crepitations only in the right lower zone.
Right, yes.
So they will have crepitations on both the sides. Of course, they will have breathing difficulty, decreased saturation. But another important point, they presented with fever. See, patient presented with fever and you are telling leukocytosis counts are very high, CRP level very high, then obviously I think that it must be a straightforward diagnosis. But if you look at simply crepitation, then it's a different story. Sometimes what happens, the pulmonary edema patients may coexist with pneumonia also. At that time they may throw fever, but this patient very clearly has only crepitation in the right lower zone, I mean right infrascapular area, that simply correlated with the chest X-ray, I mean right lower zone, there is a there are patches. So it is straightforward pneumonia definitely. Otherwise pulmonary edema they will present with crepitations on both the side and they may not have any fever. They present with sudden onset, they will have sweating, they will have sudden onset of tachycardia. So these are the way you can present, these are the way you can differentiate. But this patient clearly presents with fever, elevated CRP. Of course, the most important, the surprising phenomenon, I feel it's a newly detected diabetic. Of late in India, we have been receiving all newly detected diabetic patients who present with one another complication, something like pneumonia, or they present with a very young age DKA, or some kind of complications they present. So this patient basically for all practical purposes we deal with classical pneumonia only.
Sir, the CRP is around 250,
Yeah,
sir.
okay.
So there is some confusion between CRP and ESR.
Yeah.
Whether we have to look CRP or ESR.
Yeah, that's a good question. But basically we look at both CRP and ESR. See, what you have to understand, of course, CRP is nothing but it is one of the acute phase reactant. It is normally produced from the liver. So any infection, inflammation, both CRP and ESR will be elevated. But what you have to understand, the C-reactive protein is that is produced from the liver. So normally we have CRP, that is we used to say in a pentameric form, that CRP is anti-inflammatory basically. Okay, so each and everybody has its own normal CRP in the absence of infection and inflammation. That is called a pentameric CRP, that is very protective in nature, in the sense it is an anti-inflammatory. But when you occur infection or inflammation, what happens, liver secretes more of monomeric CRP, which we consider as a pro-inflammatory. But basically CRP, the difference between CRP and ESR, in both infection and inflammation, CRP and ESR both will be elevated. But CRP will be elevated in very short time, in the sense within 4 to 6 hours. But ESR will be elevated only after 48 hours of infection or inflammation. That's very, very important. So, any infection inflammation, CRP rises sharply, and once the infection or inflammation settles down, then CRP declines very rapidly. So, it would be very useful in assessing the prognosis and how patient improves. So, I think that you can very well rely on CRP. And moreover, if you take ESR usually will take at least 48 hours to get elevated. It is also seen in infection and inflammation. It will take long time to get subsided. So, as compared to CRP. The most important is CRP has many confounding factors. I mean, CRP naturally, when you have anemia and age and CKD. So, during these coexistent illness, so ESR level will vary. For example, when you have anemia, ESR will be elevated. So, whether you have infection or inflammations here. So, at that time the CRP would be very helpful. For all practical purpose, we could say CRP is more of specific in nature. The specificity is very high in CRP. That's very, very important, but you have to understand.
Okay, sir.
Yeah.
So, he is a newly detected diabetes patient. So, he is a young age. So, can we do C-peptide for this patient, sir?
Yeah, we can do C-peptide. Of course, we have to do C-peptide in this patient because detection of hyperglycemia, detection of diabetes, anything less than 35 years, we used to say young diabetes. So, definitely we have to differentiate whether we are dealing with type 1 diabetes or or MODY, are we dealing with MODY or type 2 diabetes. But generally, if there are any classical clinical pictures of diabetic type 2 diabetes, in the sense if they are very obese or acanthosis nigricans and dorsal pad of fat, during ultrasound examination, fatty liver and the family history, it's all may point out type 2 diabetes. In some cases, it's quite ambiguous in the sense we are not very sure what we are dealing with. But this patient presented with 561 and his HbA1c turns out to be around 13.4%. So, definitely as the question, definitely we have to do C-peptide. We can do C-peptide, something called fasting C-peptide and stimulated C-peptide. Generally we do fasting, and here stimulated C-peptide means after having mixed meals, then the patient should undergo one C-peptide testing. So, if C-peptide is very, very low, I think that it must be some 200 nanogram per ml or something, picogram per ml. If it is very, very low, then that means we are dealing with type 1 diabetes. If it is between 200 to 600, then definitely we have to think of MODY. Then more than 600, then it must be a type 2 diabetes mellitus. But I think that results yet to come. So, we have sent C-peptide in this patient. But generally we prefer C-peptide over direct insulin assay, because insulin as soon as it is secreted, it is simply degraded by liver within 2 to 3 minutes. But whereas C-peptide is not much degraded by the liver, it lasts for 30 to 45 minutes. So, we prefer C-peptide over insulin during these times basically. Of course, when insulin is secreted, so C-peptide is secreted along with insulin in equimolar amounts. That's the reason we prefer C-peptide over insulin. Both insulin and C-peptide are secreted in equimolar amounts. Once cleavage of proinsulin occurs, both are secreted in equimolar amounts, but the simple thing is the assay of C-peptide is much comfortable than the insulin. So, that is the most important what you have to remember.
We are very sure we are dealing with pneumonia. So, what are the other clinical signs of pneumonia, sir?
Okay, fine. So, other signs of clinical pneumonia, so the crepitation would be the very prominent feature. Sometimes what happen, there will be bronchial breathing. Nowadays young generation, they will fail to appreciate bronchial breathing. So, bronchial breathing, so if anybody teaches during medical colleges for young generation, you try to pick up and learn that one, very important. But they may have bronchial breathing, and they will have increased vocal fremitus, and sometimes you will have crepitation and decreased air entry also. So decreased air entry means generally, clinically we have always only two differential diagnoses. Decreased air entry means either there may be fluid collection, otherwise called pleural effusion, or there may be air collection, that's called pneumothorax. So, but only by percussion, if you percuss, if you find a stony dullness, then it must be fluid collection. If it is resonant, of course it is an pneumothorax. So in pneumonia, most of the pneumonia they will have parapneumonic effusion. So they will have associated pleural effusion. So not only crepitation, sometimes you will have crepitation, and in the lower part you may have decreased air entry, suggesting pleural effusion. That's also important for finding. You have to remember. Then another important is when it comes for treatment, the most important is whether it is an OP patient, outpatient or inpatient. That's very, very important. So you have to assess any pneumonia patient. You have to assess this patient deserves hospital admission, or he can be treated as OP patient. So for which they have there are some few parameters by which you have to assess. The most important is respiratory rate and hypotension. If somebody has respiratory rate more than 30 per minute, and when they have hypotension, I think that they are heading towards sepsis. So the earliest sign of sepsis is tachypnea. You should not forget about it. So when somebody has tachypnea and hypotension, and if age is more than 65 years, then probably they deserve more hospital admission. And apart from that, very important is some patients, they may present atypically. In older individual, they may present with confusion because of hypoxia. They will have confusion, age group more than 65 years, along with hypotension and tachypnea, and these patient deserves definitely IP. So inpatient, they have to be treated as an inpatient. That's very, very important. So the antibiotic choice would be, first you have to differentiate whether it is an community acute pneumonia or hospital acute pneumonia or ventilator associated pneumonia. But generally, if anybody comes from the community, or when they don't have any kind of past history of hospital admission recently or currently, then probably you may think that it is community acute pneumonia. If they come from community directly, then it's called community acute pneumonia. Why we have to differentiate whether community acute pneumonia? The thing is, if community acute pneumonia means the commonest organism would be Streptococcus pneumonia. Even they may respond to simple ceftriaxone also, but even community acute pneumonia patient, sometimes they may harbor drug resistant pneumococci also. For example, if they have received beta-lactam antibiotic in recent months, suppose if they have comorbid illness, diabetes and hypertension, CKD, or if they harbor chronic liver disease and heart failure, so these patients, they may harbor drug resistant pneumococci. So these patients deserve more strong antibiotics, like one beta-lactam antibiotic with one antibacterial that is targeting atypical organisms also. So that's why we prefer one beta-lactam antibiotic with antibiotic that target atypical bacteria. So here I mean atypical bacteria means Legionella pneumonia, Mycoplasma pneumonia, and so on.
Thank you, sir. You have beautifully explained, sir. In the next session, we will cover the management of pneumonia. Thank you.
Thank you.